Alzheimer's testing has been a topic that's bubbled up off and on for the last decade. And really 2 or 3 years ago, it kind of bubbled up again. Fortunately, in my opinion, with the retirement of our great colleague, Dr. Zhu and Bobbly Green, I think we have the preeminent neurologist here in this area. I'm glad that you shared your time with us, Dr. Schmidt. I'm not only interested in the topic, but I'm interested in your lens of the topic. And so tonight, we're going to do a CME on Alzheimer's testing in this application. Kira Schmidt, thank you very much.
Appreciate you. All right, just like Dr. Thornberry was saying, so the arrival of new and improved Alzheimer's testing has brought up to the forefront again what kind of testing we have, what we're going to do with it, and how should we use it. So there's a lot of different caveats to this, so I'm going to try to keep it as clinically related as possible. We could go down a very deep scientific rabbit hole, but that's not really the goal of the talk today. So we're going to focus mostly on the clinical aspects of the new Alzheimer's testing. So first, we're just going to cover the basics here. Alzheimer's disease, a lot of the patients in the area just say dementia. Colloquially, they don't know they have a diagnosis of Alzheimer's, but just to clarify for them, dementia is going to be any decline in memory or thinking that impairs functionality that we generally traditionally consider to be the primary etiologies in the brain. Okay, so if it's sleep apnea, that's not going to count as dementia. We're thinking that's predominantly related to oxygenation and breathing at night, but Alzheimer's, frontal temporal dementia, Lewy bodies, even vascular dementia falls under this range. And so that's what we're talking about with dementia. Alzheimer's disease specifically is going to be anything with that pathology with the amyloid plaques and tau tangles. So this talk is focused specifically on Alzheimer's disease, although we are going to dive into a lot of information on others, mostly to rule them out. Okay. So yes, the first thing we do with any dementia process is we need to rule out literally anything else. So most fixable stuff, we want to rule that out. Alzheimer's is kind of we almost want to have a diagnosis of exclusion initially. So we want to rule out anything. Look at the rate of onset. Was it fast? Was it slow? Alzheimer's is going to have a kind of slow, kind of staggering onset. Medical conditions. Do they have a history of strokes, B12 deficiency, folic acid, sleep apnea, HIV, syphilis, things that are treatable? We want to make sure that we get these ruled out before we even consider dementia as a possibility. Medications, again, CNS depressants, that's becoming a bigger issue as there's more and more additional CNS depressant medications available. It's hard sometimes to recognize that they're the same class or have stacking effects. So we want to make sure we really take a second look, especially as patients get older and they're absorbing those medications differently. Something that did not cause them any problems for like 15, 20 years can start to be a problem, and it's often missed. Mostly because patients are going to be resistant to changing things that have worked so well for so long. Family history, we do want to make sure that we take a look and make sure there's no family history of really odd behaviors, Alzheimer's disease really early in the day, or really early in the life cycle, things like that. After that, we want to do a cognitive assessment. So I like the MoCA. It doesn't really matter which one you use. As long as you're familiar with the ones you're using, SLUMS, MSE, any of those is fine. That gives us a little bit of an objective understanding of what's going on, and that will come into play with the Alzheimer's testing. We need to make sure that there's some sort of objective proof that there is a cognitive deficit. Okay? Neuropsych testing can also be available and can help us with this in really tough situations. And then finally, of course, looking at the neurological exam, we need to make sure there's nothing scary or cute going on. If their arm is also weak, if they have some Parkinsonism-like features, if they're aphasic, that's going to put us at concern for other types of dementias. So if they kind of feels like it's Alzheimer's, but they're also having a little bit of Parkinson's symptoms, or like they really are having a hard time with word finding, we want to start looking for other causes. All right, and then I've got the answers in there if anyone looks at the PowerPoint later. Okay, despite all of that, we are, both clinicians from primary and neurology, very terrible at identifying Alzheimer's clinically. So studies have shown they took people they thought were all appropriately diagnosed with Alzheimer's disease, and when they did a biopsy and amyloid testing later, they were wrong 30 to 40% of the time. So we are very, very bad at doing this clinically. And the reason is because there are so many mimics going on. So we want to try and rule those out as much as possible. Want to try to jump to that Alzheimer's diagnosis towards the end of the process, not early on. A lot of times once that diagnosis is made, people stop looking for other causes of thinking deficits and will miss fixable and reversible causes. So why does it matter? Well, prior to the new anti-amyloid medications, it really didn't. So once we ruled out the reversible causes, we were sure there was nothing going, we thought it was a dementia, we didn't really have a treatment for any of them. We had donepezil, memantine, those are memory boosters, but they didn't really change the disease process, and we could use them in a variety of other dementia processes as well. However, now with the anti-amyloid medications, as we discuss later, it actually will play a substantial clinical decision in patients who qualify and wish to proceed with the medication. And so suddenly early diagnosis is going to become a much bigger clinical issue. Obviously, from a research standpoint, we're always trying to get good, accurate diagnosis of Alzheimer's so we can get them in testing and things like that. But previous to these medications, clinically, it did not change the clinical course very much. So what are the anti-amyloid medications? Well, there's two. Lecanemab is the most popular one, I think just because it got FDA approval first. But there's also donanemab, which is much less likely to be used in the big cities around us. Most of them use lecanemab. Basically what they do is they clean out some of the plaques in there, and you can actually do amyloid PET testing and see that the amount of plaques goes down and the burden goes down. And there is a notable clinical benefit with that. So the way it works is they give you a series of infusions over about 18 months. And during that time, there is about a 25 to 30% slowing of cognitive decline during that window. We don't currently do multiple rounds in most cases. It's more of a one-time thing. There are some risks with it. When those plaques and amyloid deposits form, mostly they're in the brain tissue, but some of them deposit in the blood vessels of the wall. So they actually get ingrained with the vasculature of the brain. And so when we start to remove those, we can open up holes in those blood vessels. We can also cause a variety of inflammatory changes. They call them ARIA, which is the amyloid-related imaging abnormalities, which is typically referred to as like microhemorrhages. So not a full IPH or anything like that, but little microhemorrhages that form. And there's a ton of rules about how many you can have and where they go to see if you are a candidate from this medication or if you have to stop it midway through. So that's one of the things that they have to watch out for. So these medications often require an expert opinion to give them. So I know that there are different areas in the country that do it, but you really do at this point want it to be with a behavioral expert, making sure that you have someone who has experience with the imaging changes, experience with the bleeding risks, and the ability to get PET amyloid scans and things like that that are often followed is vital. So before we send someone all the way to Louisville to get this done, we want to know if that's a good candidate for it, okay? So criteria for use. So let's say you have someone, you're pretty sure they have Alzheimer's. We do have some limits. So we don't want a patient that's very far along in the disease. So remember how those amyloids go in the blood vessels? The longer you have the disease, the more they're in the blood vessels. So if you take someone in the later stages, they're definitely going to have bleeding and end up stopping. So we don't take people later in the disease process. The thought is also that they're not going to benefit as much. So that finer cognitive ability is already lost. And so we really want these people early on. So looking around at the local areas, most people want either an MMSE between 22 or 30 or a MoCA between 13 and 20. This is extremely subjective to the place and their functional capacity. So I've got patients who on a good day, their MoCA would have been 18 already. At 13 is not half bad. They haven't essentially functionally declined. They may be a good candidate. Whereas I have patients whose MoCA score is in the mid-20s and they can't use a remote anymore. So there is some subjectiveness to it. We need to confirm that they actually do in fact have Alzheimer's disease. And so currently the most common way of doing that is with the amyloid test, but there are other options that we're going to talk about in the future. We need to have no previous head bleeding to suggest an increased risk of bleeding with this medication. So they can't have more than 4 microhemorrhages. Anticoagulation, generally considered not optimal, though there are some centers that do it with anticoagulation. So if you have a patient who really, really wants to, you can, but most of the time I'll tell patients that it's a relative contraindication and we don't even dive into this conversation. Okay. The biggest thing, and no severe white matter disease. The biggest thing is that they need to have cognitive symptoms. So this medication, though studied actively in patients who are preclinical, does not have an FDA approval and should not be used in patients who do not have a clear cognitive dysfunction. So I do have every once in a while patients come in and they say, well, I've got a strong family history of it. I want to get screened for it. I want that medication to prevent myself from getting Alzheimer's. Sometimes I leave my keys in the wrong part of the counter. That is not going to be a good candidate for this. They need to have clear on the testing decline in their cognitive function, okay?
Could you expand on that a little bit, or what you mean by cognitive symptoms? Like, you know, when you have the elderly people that come in, they'll get to 60, like, I can't remember like I was when I was 30. What's the line for you as a working neurologist?
For me, it's if there's functional decline. So if they're saying they're forgetting their keys or they're missing a couple words, but they're able to get about their daily life, it's not stopping them from being social. It's not stopping them from driving, or like they cannot find it. You know, they'll say, I couldn't remember what I went to the store for, but if they can remember while they're there, or they get disoriented while driving, but they make it anyway, those are some of the things you really want to rule out those mimickers for. Things that are concerning are if they can no longer do a task they used to do because of thinking difficulties. So for example, I got like mechanics who everything's fine in their life. They manage their meds, they do okay, but you know, they just can't put the car back together. Like they just can't finish the jigsaw puzzles they used to do. They can't quite manage their meds like they used to. They got a tax person. Taxes just got too hard that year, even though nothing major has changed. So those are the kind of things you want to look for. Did it make a notable change in their behavior? If they can get away with a couple post-it notes or things like that, a little less worried. Want to look for those mimickers, sleep apnea, B12 deficiency, those kinds of things. Yeah. All right, so anti-amyloid, I'm going to sum it up real quick. It works the best the earlier we use it. So the best time to keep those finer cognitive functions that really make a difference in the patient's clinical progression and ability to live their life is going to be early on. So we want to use it as early as possible. Safety-wise, also, the earlier the better. The less likely there's going to be amyloid plaques in the blood vessels, the less likely we're going to have bleeding and things like that. The problem is just like with multiple sclerosis, the earlier you try to get a diagnosis, the harder it's going to be. And so that's what some of this testing is helpful for. So we need to have at least a high suspicion of Alzheimer's disease, either clinically or from the testing that we're going to talk about. And again, we must have cognitive deficits. So we do not want to use this prophylactically right now. That may change in the future. There's a number of ongoing studies about using it prophylactically, but right now we do not in a general clinical setting. Okay. So what did they use before the amyloid testing? Well, they had an amyloid PET. It's actually a radio tracer, binds to the plaques itself, and they actually still use this in the clinics that use these anti-amyloid medications. So this is considered the gold standard. Whenever they're relating anything to anything in terms of sensitivity, specificity, they are talking about an amyloid PET. The problem is that one is extremely expensive. It's several $1,000s. It is very subjective. It requires a highly trained and highly experienced radiologist to read it, in addition to neurological input, but they need to read a good number of these to be able to adequately read it. And of course, it's got limited availability because of those things. So it's pretty much isolated to the major centers. I think you need to go to Louisville, Lexington, or Vanderbilt for it. I don't believe that Bowling Green has access to this currently. MRI of the brain, so that's what we used before all these fancy stuff came out. Unfortunately, it is very non-specific. So though there are lots of studies about what areas of the brain become atrophied more and such things like that, in actual clinical practice, it's nearly impossible to see those, especially early on. Those changes are tending to be seen more in the end stage, and at that point, it's not clinically helpful anymore. We've pretty much already guaranteed we know they have Alzheimer's disease just from progression alone. But there will still be some people that get this, and you will still see some of the bigger cities comment on the areas of atrophy relating to Alzheimer's specifically the temporal and the parietal area. And that's just a picture of the amyloid PET there. That negative one is A and the positive one is B, so you can see that dark stuff, much higher plaque burden there. So when we first started looking for markers, because we needed something to help us with some of these medications and research processes, we did use spinal fluid. So there were concentrations of a number of different things, from different amyloid plaques, different tau markers, total tau, etc. There's a tremendous amount of studies that all look into different variations of it. And it was traditionally listed as simply positive or negative. But after they were able to do all these, they actually were able to get it a little bit finer than that. And we'll talk about that a little later. But you can actually kind of give some information on other dementia processes as well. The problem is this is invasive. So trying to LP everyone who you think might have Alzheimer's disease is probably not going to be optimal from both a safety standpoint or a practical standpoint, as it's very time consuming and it requires a lot of additional work and risk. So we didn't really use these heavily. Then came our blood markers. Again, concentrations of the same proteins, tau, etc., much easier to obtain, very low cost, fairly good coverage at this point. The problem is that there are many versions of it. So you'd think we'd come up with just one test, but actually each test is going to be its own combination of these different markers, and each one is going to have their own sensitivity and specificity. They also have some limitations that a lot of physicians are not aware of. So things like kidney disease leads to false positives. So you think of all the patients you have that have Alzheimer's symptoms plus CKD, those tests may be positive, but that may be a false positive, and we don't have a good way of adjusting for that, so we kind of just avoid using it in patients with CKD right now. And there's some other ones as well, like the use of biotin will also cause false positives, and so that's not something that's regularly listed on med lists, so it's something you want to keep in mind if we're going to order this test. So here, for example, is a list of some of the major providers for this. So you can see each company has not only its own separate test, but its own separate versions of the same test, which unfortunately has led to some difficulties reading it. So what I usually recommend is you figure out what your typical lab does, get a hold of a copy of it, and really look at the details, because there will be some subtle changes, whether it's less than, greater than, the number and required will change. The good news is that if you look at it as a whole, it usually will fall down into one of these categories. And some of the nicer tests will actually just tell you A plus, T plus, N plus, or something like that. That is obviously the easiest to read, and this is available both here and online as well. If you just Google ATN testing, you'll see the studies that have it listed out for you. Little bit easier to read. You just want to make sure that if your study doesn't tell you what the AT and N are in the details of it, it will list it out. You just have to make sure you know where your reference numbers are. Okay. Luckily, LabCorp's one usually just tells you what it is, but I do sometimes get it back when it does not have it, and we have to actually sit down and do the math a little bit. Okay. So you can see here, one of the easiest ways to remember it is if it's A plus, then we're worried about a little bit in that Alzheimer's range. If you want to do the testing, it's got to be A plus, T plus. So that actually helps us a little bit. It seems overwhelming, but it's actually fairly divided in a way that you can kind of keep straightforward. We actually just printed this out and put it on our wall because we get so many of them. Okay. There are lots of studies looking into what these non-clearly Alzheimer's disease patterns are. So there's some that are like in that Alzheimer's continuum where they're on the fringe, where we think they might be some kind of Alzheimer's or sub-Alzheimer's adjacent disease. We haven't quite figured that out, so we don't consider that to be positive at this time. We also have a non-Alzheimer's pathological change, which means there's something going on, but we don't have enough sensitivity in population studies yet to know exactly what that means. But it does lead to concern that there could be some other dementia process going on, whether that be frontotemporal dementia or prior strokes or some other active process. And of course, if it's negative, then that would be normal, if all of them are negative. So are they accurate? Well, they're pretty accurate actually. So they've got upwards of 90% sensitivity and specificity. It does change on the study, but it's required to be at least 90 right now for these studies to be FDA approved and out there. So, They have feelings, the neurologists, on which ones are more accurate than others, and currently they think the p-tau is the most accurate, but they have not provided any strict guidelines on exactly how to read that. So I don't worry about that right now. We pretty much just stick with this picture right here. There are a lot of confounders to this, and it's really important if you're going to order it. I've got them all listed here. You can Google them online as well. But there are some things that are going to affect the testing, and what we don't want to do is give them a false positive, because that could make major changes, require a bunch of additional tests. Even if they go all the way and they find their PET amyloid is negative, we've still wasted thousands of dollars in time for the patient. Okay, so biotin, which is a common supplement, often not listed on the list, is one of the major ones. So you need to stop at 72 hours before the test. So you have to ask your patients, do you take any biotin before the test is done? Otherwise, it could be falsely inaccurate. Chronic kidney disease is one of the biggest ones for us. They are coming up with some adjustment factors, but they have not clearly done so yet. So right now, I personally do not order it in patients with CKD. That may be an upcoming thing in the next few months to years as they get more familiar with it. But right now, we consider that to be an unreadable test. Okay. But CKD is probably going to be the one you run into most commonly. So try to avoid ordering it unless you, basically, if they have CKD, we need to test them a different way, either through the CSF, or we can consider a PET amyloid if we feel strongly about it and they want to do the medication. Okay. And then, of course, there are some other adjustments for some rare conditions like tuberous sclerosis causes intracranial changes and actually kind of mimics the same pattern. So we do have to keep those in mind, although that's less frequently. We don't know what to do about serial testing. So if someone's right on the border and you test again and it's a little bit under the border, we're not quite sure what to do with that yet. So these are all some caveats due to the fact that this is a relatively new test. Also due to the fact that there's relatively a large number of versions of it. All right, so all those caveats, all those things, when do we test it? Again, must have cognitive symptoms. So functional decline, positive cognitive testing. That means that there is an abnormality on that cognitive testing, okay? We have to believe that there's at least a possibility that they could have Alzheimer's disease. Currently, the blood testing has a cutoff of 50 years old. So we don't really consider anyone less than 50 unless they have a super rare whole family has Alzheimer's at 45. They probably ought to see a neurologist anyway. But because we need to get this testing done and evaluated for those medications as early as possible, both for safety and efficacy, unfortunately, a lot of times by the time they get to us in the neurology clinic, we are well past both the range for cognitive function and well past the ability for them to get to a larger city. So unfortunately, most of this testing is going to be, if we're going to get that window of good benefit from the meds, it's going to have to be really done before they make it to the neurology clinic. And that's why we're really talking about all this information, because unfortunately, frontline is going to be primary care physicians, as it always is. So what do we not use it to do? We do not screen it, regardless of the patient history. I always just want to harp on that because I do get a lot of consults for patients who don't have any cognitive deficits, who got it because they have a strong family history of Alzheimer's, and then it's positive. We don't know what to do with that. So we don't know if that means that they're going to get it. We don't know if they should be on the meds. We don't know anything. So it generally just causes a ton of stress and basically psychiatric problems with the patients because we don't know what to do with that information. They feel like that's going to hang over their head forever. And of course, if it's negative, it does not mean they don't have Alzheimer's in their future. Okay. So I got a couple examples to try and make this a little bit clearer. So we got a gentleman, he's 75 years old. He has known sleep apnea, but he failed multiple trials. He tried every mask on the market. He didn't want to do Inspire. He could not make it work. He's got high blood pressure. He's got cholesterol issues, fairly active, retired mechanic. Wife's worried because he took his car apart, couldn't put it back together. Getting lost while driving, but he's able to kind of get back on his own. We got a picture of his MRI, nothing scary, age-appropriate atrophy. Labs look fine, B12, folic acid, syphilis, HIV. All of those came back completely negative. On his MoCA score, he does have kind of low, mild cognitive dysfunction at 20 out of 30. Just for reference, it should be 26 or higher if it's going to be normal. Okay, so what do we want to do with this gentleman? Should we test or not test? What you want to do is you want to go through those steps. So one, does he have cognitive issues? The driving could go either way, but yes, he does. So he has a MoCA score that's abnormal. He can no longer do the tasks he used to do because he can't cognitively think through it. It's impacting his life. He can't do his hobbies. Wife has noticed a notable change in his abilities. Is there a clinical concern he could have Alzheimer's disease? Yes, he's appropriate age. He has, basically that's it. He's an appropriate age and the symptoms match. It's kind of slow, it's not rapid, there's no weird stuff. We didn't notice any Parkinson's disease. So there's some serious concern that this might be Alzheimer's disease. Then we have to ask, does the patient want to get tested? Right now, this testing mostly just tells us whether or not we can be applicants for the anti-amyloid testing. If they do not want anti-amyloid medications, if they don't want them, it doesn't matter. Because if it's positive or negative, we're going to do the exact same thing. I usually just tell patients that, hey, if you want to consider this medication, we got to do this test. The earlier, the better. It could come back positive. Then we'd have to go to a big city and consider the testing or the medication, or it could come back negative. And then if they say, I don't want the testing or I don't want the medication, then you can ask, well, do you still want the testing? It could show positive. You know you have Alzheimer's. Do you want to know that? Knowing that, it's not going to make a big change clinically on what we do, since we're not doing the anti-amyloid medication. Historically, my experience is that patients do not want it. So they usually do not. They don't want to know, they're going to do the same thing. The only patients that I've seen that regularly say yes to ATN testing are the ones who are young, fairly active, early in the disease process, and they want to consider the anti-amyloid medications. And unfortunately, we're missing a lot of those. So I see them much too late, unfortunately, for that. Okay. And then, of course, make sure they don't have CKD or they're on biotin, please, or they have tuberous sclerosis. Okay, and that just says all those things. So yes, he meets both criteria. Always ask before testing because there can be a lot of issues, kind of like Huntington's testing. Some people just don't want to know. Some people don't want to know. Questions about that? Perfect. Okay, example 2. We got a college professor. He's 55 years old. He's got high blood pressure, depression. He's making his CPAP work. It's not a fun time, but he's making it work. His wife's noticed, family knows, he's kind of repeating some questions. He's had some episodes of confusion when he gets the flu or things like that. Work's been fine, no family history. MRI is completely normal. Labs are 100% benign. There's no nutritional issues, no infectious issues. His MoCA is about a little touch low at 25 out of 30. Thoughts on this? Does he meet criteria for cognitive deficits? So in this case, yes, I probably would consider it. You know, he's saying there's an issue, he's repeating stuff. That alone's not enough, but this is a college professor who is working in a high-functioning mental job, and his MoCA score is 25 out of 30. That's not going to be quite right. So he's starting to notice there's something going on. Do we think there's a possibility of Alzheimer's? Maybe. I wouldn't say it's strong, but he is over 50 years old and he is having cognitive issues. We've ruled out as best we can everything else. We've tried to treat his sleep apnea best we can. At this point, he would potentially be a good candidate for anti-amyloid medications if he wanted to. So we ask him, do you want to get tested or not? If you don't want to take the medicine, do you still want to get tested? And we look to make sure there's no co-founders. So make sure there's no biotin, make sure there's no CKD. Okay. That is actually a real example that they used at the AAN, and that patient did in fact have Alzheimer's disease. So he did get the anti-amyloid medications and theoretically experienced the benefits of it as well.
This patient, did it have serology screening?
Yes, he had lab serology screening, which was positive. He did want to do it. They got the testing, and they actually, because he was so young and there was a lower suspicion, they actually did go on to do an amyloid PET scan, which did confirm that he had it. And then after the anti-amyloid medications, they repeated the PET scan and showed that there was a notable decrease in the amount of plaque burden.
The thing I want to know, if they have that available, maybe it wasn't, but you know, at 3 to 5 years, this would be like the quintessential case of, you would hope that if the treatment was going to be sustainable and really actionable, this would be the patient you would want.
Yes.
And they get a great outcome. In 5 years, did they look the same? Was it disappointing? Was it more impressive than we thought it would be in this select group? This would give me a lot of hope.
Yeah, it does have clear clinical benefits. So they have enough, it's been out long enough and they've had enough styles that it does have that 25 to 30%. And that does buy you about 6 to 9 months of good cognitive benefit. So it doesn't cure Alzheimer's, it's still gonna happen. But a lot of patients, that's the biggest quality of life, is those first early years of Alzheimer's disease. And then it will progress after that. We can't stop that progression from happening. It doesn't change the way the rest of it progresses, but it does delay it. Okay? Kind of like palliative chemo. You know, it can slow it down and it can give them some really good time, especially if they want to make it to something specific. They want to retire, they want to get their affairs in order, they want to see their kids, you know, remember their kids' wedding, things like that. So it can have some benefit, but it does have its limitations. Now, a lot of patients decide that the work and effort of going up to getting multiple MRIs, getting the testing, getting all those things aren't worth that 6 additional months, and they choose not to do it even if they're in that window. All right, so here's a third example. 60-year-old male, he's got depression, diabetes, COPD. He has a very strong history of Alzheimer's disease, very early, as early as the 50s even. Now he's saying, okay, I'm forgetting where I'm putting things, but he hasn't had any functional decline at work or family. The family themselves aren't concerned about his behavior. MRI is normal. Labs and mimic rule out are normal. He doesn't have sleep apnea. His MoCA score is 29 out of 30. So we ask our questions, does he have any cognitive issues? No. So MoCA score is fine, no functional decline, no significant concerns from family. He doesn't meet that criteria, though he is understandably worried about the potential for Alzheimer's in the future. If we get that test and it's positive, there's nothing we can do about it. So then he's just going to feel like that's hanging over his head even more than before. Again, that could change at any time. If the currently ongoing tests show that there's benefit to that, right now, there's no indication that that's the case. So we do not give it for patients who do not have clinical symptoms. And as a result, we don't want to give them that test because then they're going to be looking for it. Okay. All right, I'm just going to sum this up. So why does it matter for PCPs in general? And that's why we kind of decided to have this talk, is because it's really important that we get it as early as possible. In the patients that are good candidates, the earlier the better is the case. We want to make sure we don't over-test it, make sure we rule out the mimics, but in the end, by the time they often get to secondary care with neurology, it's well and by far too late. That benefit window is substantially narrower, the risks are substantially higher, because it's going to take, unfortunately in this area, another several months to get set up at Louisville, et cetera, to get the testing actually done, and then we'll have further decline in that window, unfortunately. Why does it matter? Well, patients are going to start asking about this test. As they start to use it more, they're going to know family members who are positive. They're going to be like Googling, how do I find out if I have Alzheimer's? And they're going to start asking you about it. And it's really important that we don't give it to patients who don't have cognitive symptoms, because we don't know what to do with that. Okay. And then, of course, there is a limited access to neurology. So even here, our limits, our wait time is like 3 to 6 months, but in Somerset, it's like a year, year and a half. Bowling Green's also several months. So a lot of times that frontline decision, that first year or two of the Alzheimer's process, they're not going to see neurology. And so unfortunately, that'll end up on all of our primary care doctors. All right, then 1 million citations. Questions?
For the screening criteria, then does it matter in their history if it was a traumatic brain injury that they've had, if that's to allow them to be able to qualify for the criteria for use, or? Technically, no. The current rule is no bleeding, but could you find someone that would do it? Probably yes. Especially if you could clearly document, like you had records that it was clearly a traumatic injury to the head and you had MRIs from that time and everything was clear, you probably could convince one to do it. Yeah. They'll even do it with anticoagulation more recently. That's been a more recent thing.
The anticoagulants include antiplatelets or just strictly?
Just full anticoagulation. Yeah, warfarin, Eliquis, those kinds of things. All right. Well, that's pretty much all I had.
There are 2 or 3 things I definitely want to
Oh,
review with the house staff. The first thing I'd say is we don't order a test unless we know what we're going to do with it. it's just a golden rule. There's testing used to be trouble in 2 ways. One, when you order tests, you leave, you don't tell somebody about it. I've seen a lot of applicants have a lot of house staff because of that. You just can't do that, even when you first start. And we don't order any tests unless we know what we're going to do with it. If we don't know, we need to talk to a senior resident, one of the attendings, and say, well, how do we manage cases like this? So that's just, when we're talking about testing, that's something we got to talk about together. Second thing is, in the clinic, you're definitely going to see people come in and talk about statins. Statins give you Alzheimer's. And that has been clearly debunked, and that's in the literature. And I just put that in the category of, I get that with metformin, aspirin, coffee, statins. Anybody that takes 10 million things, anybody that clicks, they want to click. And they will sensationalize anything. That has been debunked. There might a few small percentage, 10 or 20% may have little cognitive change for a month, but that resolves fully. The third thing I think that you probably want to consider is when it comes to when you're out in the real world. I had a conversation with our neurologist about a year ago on this when it was on my agenda, and I want to take the direction from them. I mean, these people are the people that we're going to be consulting with. And I think in a case like this, how would I handle this? What's the take on for me? If I have a quintessential patient, I have a college professor, somebody that's a physician colleague, an attorney, somebody very high cerebral, very young, maybe still have a family, those people might be the ideal candidate. I'm probably going to identify that as a very high-risk person, and I'm going to probably say, would you want to, if this all works out, would you want to move forward in this direction? I would move in that direction. Most of the other candidates at this point are probably not great candidates, and there's a but to that. And this is my personal take, and I apologize for taking Dr. Schmidt's time here, but we're coming into an era that I work with every day, and there was a time before antibiotics when people just died of infection, and a time after when they hardly ever died of infection. We're coming to an era of artificial intelligence, and a rough rule of thumb here is, now this is a logarithmic progression, but even as we are today, about a year of AI research is about 10 years of what used to be the old type of research. And so really I'm playing with these types of things. Can I play the game long enough to keep it in the game long enough for some dramatic breakthrough? Do I think it's going to happen in 2 to 3 years? Probably not. 7 years? I mean, can you imagine where we were 3 years ago before artificial intelligence started? And now you can't go throughout the day and not hear about it. It's invading everything, and it's going to invade our field because there's a right and wrong answer. That's why math becomes good. You're either right or wrong. In our field, the patient gets better or they don't. There are things to see, and a lot of the testing we're doing now is in the software, right? We're not putting rat models out, we're putting artificial intelligence models out. And I think these types of things, particularly neurologic diseases, I don't know how you feel about it, Dr. Schmidt, but I just think things like, multiple sclerosis, Parkinson's, dementias, I think this is going to be a dramatic, I think the sun is really going to shine on this. Maybe not now, but somewhere maybe 7 to 15 years from now, it's going to be a completely different game. And maybe, again, maybe it's not as optimistic today. Maybe you get a year or a year and a half. But what if we get that year and a half to 4 years? What if I get it to 9 years? And you start treating like advanced lung cancers, like chronic diseases. What if we get that, and then we're just vying for the time when we get some substantial breakthrough that would really matter? This not be the burgeoning of that. And I think you guys in your careers are going to be around. I mean, not going to be around for it. I think we're going to have to live it. But those are the comments that I will make to our new colleagues. Thank you.
Thank you.